Hi, I'm Ashish Jha. I'm an internist and I'm a professor of health policy at the Harvard School of Public Health. And today I want to talk a little bit about quality of care from a global perspective. I'm going to start off first talking a little bit about the history of the quality movement in the United States and what it has taught us. And then I'm going to talk about how this compares with what we know about healthcare quality issues more globally. And then I'm going to finish up with a synthesis of what does the global perspective teach us about improving healthcare in America. So until the 1980s, the assumption was if you went to a licensed physician, you went to an accredited hospital, you would get high quality healthcare. And in the 1980s, something interesting happened. An IT revolution began. The microprocessor started getting faster. Our ability to store and analyze data started improving. And so our ability to study quality and our ability to examine what was happening in hospitals and in doctors' offices really started getting much better. And what we realized was that there were serious problems with healthcare quality that were pretty ubiquitous. And into the 90s, as the studies kept rolling in, we realized there were three major problems, at least three major problems with healthcare quality in America. First, we realized that medical errors were a major source of morbidity and mortality. People were dying, people were being injured because of medical errors. The second thing we realized, really coming out of data around 2002, 2003, was that the right care was delivered about half the time. That when you walked into a doctor's office, when you walked into an emergency room, you only got the care you needed about half the time. And then finally, we started getting data that told us that patients often had very poor experience with their care. That even when they got the right care, even when they got safe care, their experience with that care, the respect with which they were treated, was just not nearly as good as it could be. And if we fast forward to today and ask, where are we today in 2014? What do we know about the state of healthcare quality in America? All of those problems persist. The latest data suggests that when seniors are admitted to hospitals, maybe as much as 1 in 4 is injured during that hospitalization from the medical care that is intended to help them. We still know that care is too often unreliable. There are huge variations in outcomes. You can go to one hospital and have a very different chance of dying from your heart attack than if you end up at a different hospital. And key processes for things like diabetes and hypertension and heart disease are still not done reliably. And finally, despite all the talk and all of the focus on patient-centered care, we know too many patients still have experiences that are really quite suboptimal. So this begs the question, are these problems uniquely American? Is this really a product of just the American healthcare system, or are these challenges that other countries face as well? And now I'm going to show you some data that hopefully suggests that this is a very complex picture. This is a slide from some work that has been done at the Commonwealth Fund, which asks patients when they leave the hospital, what proportion of times did people carefully examine the medications you were being discharged on and reconcile them with what medications you were getting at home. This is a key metric of quality. We know that during transitions of care, for instance, when patients leave the hospital, reconciling their medication list to make sure what medications they're getting is critically important. And this data shows that the US is actually pretty good on this. Compared to 7 other high-income countries, what we see is the US is just behind Germany as in terms of comparison to other countries in terms of doing this well. The next slide shows you how often patients are involved in key decisions. This is based on survey work where patients were asked, were you critically involved in decisions that affected your care? You can see that the OECD average is around 85%. What you also see is the US is just below the OECD average. Not terrible, not great, but about average across all of the OECD countries. OECD countries are the large, high-income countries in Europe and North America, and the US does about average on this. The next slide shows you data on in-hospital mortality rates for acute MI. This is when patients come into the hospital for their heart attack. What are the chances that they're going to die in the hospital? We can see that the OECD average is about 5.4%, and the US actually does much better. about 20% lower mortality rates for acute MI. This compares quite favorably to other countries like Belgium and Japan, and certainly Mexico, that has much higher mortality rates. When we look at mortality rates for hemorrhagic stroke, on the other hand, this is another condition that has high morbidity and mortality. Here, the US actually does worse than average. Our mortality rate is about 10% higher than it is on average across the OECD countries. And some of the countries that did poorly on the previous measure, Japan, for instance, actually does very well for hemorrhagic stroke. And finally, this is a slide that looks at how often patients develop sepsis after abdominal surgery. Major surgery, infections are a major source of complication. And here, we can see the OECD average in the gray bar, and what you can see is the US actually does much better than the OECD average. And countries like Canada and New Zealand and Spain end up doing much, much worse. So what do we make of all these data? How do we understand this? Well, first and foremost, I think what's really clear is that quality problems are ubiquitous across the globe. They are not uniquely American. The best data on quality issues, quality, patient safety issues, really come from high-income countries. But in the last few years, we've seen a lot of new information coming out of low and middle-income countries like China and India and Thailand. And what those data tell us is that the problems are just as bad, maybe even worse, in those low and middle-income countries. The second key lesson is that no nation seems to do consistently well. On some metrics, we do very well. On other metrics, we do not so well. And no country consistently performs well or consistently performs poorly on any of these metrics. And that leads to the third conclusion, which is that there is no specific single model for healthcare financing that seems to consistently deliver high-quality healthcare better. So there are some countries that are single-payer, like Canada or England. There are countries that are multi-payer, like us, Switzerland, or Germany. When you look at quality performance of the single-payer versus multi-payer countries, you don't see a big difference. Similarly, when you look at countries that are primarily private, such as Switzerland, versus countries that are primarily publicly financed, such as England, you don't see big differences in quality. And what that tells us is that the problems with quality are not about simple notions such as it's a problem of multi-payer or single-payer or private or public payers or private or public providers, that the problems are more complex than that. So what we have learned over the last few years is that quality is something that every country around the globe is increasingly focused on. And it's because as countries focus on access, as countries focus on ensuring that people can get into the healthcare system, they realize that the goal of healthcare is to improve health. And the only way we're going to get there is if we not just give people access to healthcare, but we make sure that that care is worth giving access to, that that care is safe, that care is effective, that care is efficiently and delivered in a patient-centered way. And this is a place where the US has been a leader for nearly 3 decades. While we still have much to learn, we also have a lot to teach other countries in this area. So finishing up, quality is a property of the healthcare system. You don't achieve high-quality healthcare simply through a new financing mechanism. You get to high-quality healthcare through focus, through attention, through hard work. This is an area where the US has been a leader. For 3 decades, we have been working on defining the size of the problem. We have been leading efforts on measurement. We have been leading efforts on transparency. We have more publicly reported data on quality performance for providers, hospitals, insurance plans than any other country in the world. And for more than a decade, we have been experimenting with pay-for-performance schemes. How do we tie incentives to improve quality? While we haven't gotten all those issues right, we have been working on this longer and harder than anybody else. And so while the US continues to face substantial challenges in making sure that everybody gets safe and effective care, it continues to lead on developing measures, on transparency, and pay for performance. And these lessons will be critical for the whole world as it seeks to improve the quality of healthcare that people get.